Healthcare Improvement Scotland's annual review. Can I just begin with a few housekeeping messages? Should anyone not be able to hear any of the discussions during the morning, please let me know and we'll make sure that we adjust the volume so that you can hear us all. There is no fire alarm expected, so if we hear one, please follow the fire warden's instructions if they require us to evacuate the building. Can you please turn off or turn to silent all your mobile phones? And just to let you know, we have a photographer in the room, Stephen, who is at the back, who's taking photographs during the session. If anyone is uncomfortable and doesn't wish their photograph to be taken or used, please let Stephen know. So a warm welcome to you all. It is good to see so many of you here and to see the breadth of interests. And it's particularly good to see colleagues from health and social care and for the wider public sector. And I personally enjoyed meeting a few old friends from my previous life who I'd not seen for some time. We are web streaming the event today for the first time. So welcome to those of us who are joining us. We hope it goes well, but please bear with us as we are novices at this stage. It goes without saying that this is an important event for HIS, an opportunity for us to report and to reflect on our work during 2017-2018, to identify progress and areas for further work and improvement. HIS is in a unique position of being able to see the bigger picture, see how different parts of the system fit together, and where they don't, help to bring them together. Our approach is underpinned by evidence and data and influenced by the views of the public and health and social care professionals, many of whom are in the room this morning. So let me explain the format and the programme. This year, as a national board, we are only expected to hold a public meeting. We have a separate private meeting with the Cabinet Secretary, which Robbie and I will be held to account. So we will begin by reporting our achievements during 2017-18. We'll then receive feedback from our partners, ask our guest reviewers for their questions, and then move to questions from the audience. I would ask each of our speakers to be as concise as possible, as it's really important that we create as much opportunity at the end of the formal presentations for our audience to ask questions. And finally, in closing, we will look forward. I would now like to invite Dr. Hamish Wilson, Vice Chair of Healthcare Improvement Scotland, to present our progress and achievements.
Thanks very much, and thanks to Carol for the introduction. This is officially the annual review 2017-18, but realistically we're in November, so we can't avoid, I think, talking a bit about what's happened in the rest of 2018. So there'll be a bit of that as we go through. But I just wanted also to mention that the person who would normally be doing this for 2017-18 would be Denise Coyer, because she was chair of Healthcare Improvement Scotland for that whole year. And obviously, because Denise has demitted office, I've been asked to do that in her place. So, but I did really want to pay tribute to the work of Denise Coyer, who was chair of this organisation from its inception right through until just a couple of months ago. So I don't think we should let this opportunity pass without paying that tribute. Equally, I want to welcome, on behalf of Healthcare Improvement Scotland, Carol as our new chair, and it's great to have her here today. Okay, let me say a bit about Healthcare Improvement Scotland in 2017-18. Let me start with the honeycomb. That's what we've called this. The purpose of did that not come up? It's come up on my screen. Bring the technology guys back. I can talk for a bit if you want. I could tell jokes if I could remember any. Jason's very good at telling jokes.
Anything with jokes in.
All right. It was working great earlier on, I promise you, it really was. All right. Right, that was what I was wanting to show you. And it was on my screen, so I started talking about it. Yes, we called this a honeycomb. The purpose of it is to remind you that we are an organisation of many parts, but with one purpose. And one of the things I want to try and stress as I go through this presentation is that point about one purpose. Our organisation is called Healthcare Improvement Scotland. It was called that intentionally because that is our focus, improvement. And I want to keep coming back to that. So again, let me say a bit more about how, as an organisation, we seek to encourage and support improvement across health and social care. It's really important, I think, that we start with the public voice. We're seeking, and we have sought over the last 7 or 8 years, to strengthen the patient and public voice, not just in what we do, but in the organisations with whom we work in health and social care. And many people will assume that that is the work just of the Scottish Health Council. And this is not to minimise the work of the Scottish Health Council, but it's not just them. The intention is, and our aim is, to ensure that we make that public voice count in everything that we do. But I will mention the Scottish Health Council because it's an extremely important part of the organisation. And when you talk about them, there's almost an inevitable public focus on service change. So yes, in 2017-18, the Health Council supported patient and public involvement in about 65 service change proposals across Scotland. So that might hit the headlines, but a whole lot of the work of the Health Council and of Healthcare Improvement Scotland isn't as visible as that to the public, but it is visible at local level. And it's visible in the outputs which come from our organisation. And let me just give you 1 or 2 examples of that. One of our teams has been involved in developing the standards for the care of children, young people and adults who've experienced rape, sexual assault or child abuse. And the work of that team in involving people with lived experience has meant that the standards which are being produced really do reflect what matters to people. The Patient Safety Programme for Mental Health worked with the Carers Trust Scotland, talking about what does it feel like with a mental health problem living in remote and rural areas where access to services are not as easy as they may be in some other parts of Scotland. Voices Scotland, under that banner, a group of people with learning disability shared their experience of discrimination when accessing services, all with the intention of improving the services provided and addressing that discrimination. So there's a whole range of involvement, both at national and at local level. I said I would mention 2018 generally. 2018 was an anniversary, is an anniversary, it's still 2018, for the NHS in Scotland. 70 years of the NHS in Scotland, 50 years of social work from the Social Work Scotland Act in 1968. And we've got a couple of anniversaries, and I wanted to focus on 2 of those. And the first of those is 10 years of the Patient Safety Programme. And it's really important that we do celebrate that absolutely fundamental programme in promoting safety and quality within healthcare within Scotland. If you go back to 2008, the evidence around the admissions to hospital where people were unintentionally harmed and the potential for avoidance of incidents was very stark. And I do want to mention Jason at this point, because without the impetus and support and drive from Jason, we wouldn't be sitting here, I think, talking so purposefully and so positively about the patient safety programme. It started off in acute, but it's extended now to medicines, mental health, general practice, dentistry, community pharmacy, care homes, maternity, neonatal and paediatric settings. So virtually the whole spectrum is now covered by aspects of the patient safety programme. So some headlines. You may not be able to read all of that, but you can see the detail in the documents which are available for you today. But let me just highlight one or two of these. Again, I'm back to, this isn't just 2017-18. This is an ongoing programme. You don't achieve these kinds of results in 1 year. Yes, you can make a difference, but you have to look at it over the longer term. So, over 550 patients a year in acute hospitals are now spared the pain and additional treatment required from pressure ulcers. And that's being spread from the acute sector into care homes. The mortality rate from sepsis has decreased since 2012 by 21%. A reduction in neonatal mortality since 2013 by 17.4%, and a reduction in stillbirth rate by 22.5%. And when these notes were written, a 9.2% reduction in hospital standardised mortality rate compared to 2014, and I think that figure has changed since these notes were made. So those are just examples of what SP has brought about since 2008. But the figures, while they're important, often don't give that kind of personal feel. So with a bit of luck, this video will work. He said, crossing his fingers. And this is Vary McKinnon, who's a senior charge nurse in NHS Highland. Yes.
SPSP Acute Adult means to me it's really brought structure and organisation to the improvement of safety measures for all our patients in our care. It's really motivating and educational, and I don't know where we'd be without it now, honestly. The greatest achievement for me is noticing the reduction in cardiac arrest with all the amazing work that's been happening around deteriorating patient and the news and things like that. I'm 22 years nursing now, and very rarely do I see a cardiac arrest, whereas it was kind of normal before. The key ingredients for the success really has to be ownership at ward level, using the improvement methodologies, and staff is very much embedded in the culture that improvement and change is on the cards and people expect it now. The impact in the world of improvement has to be that it is normal to make everything safer for our patients nowadays, and it's everybody expects the next improvement coming along and the next looking for change to continually make things better. The priorities, certainly in the area that I work in, would be recognition and management of delirium. We know that there's a 11% increase in mortality for every 48 hours that goes undetected. And I believe that if we fight delirium, then we're going to prevent sepsis, and again, we're going to save patients' lives. The three words I would use to describe SPSP Acute Adult would be motivating, educational and life-saving.
Much better coming from her than from me. let me go back to some more infographics. And again, there's a lot on the screen. Don't seek to read it now, but if you have the chance, pick up a report from the iHub. The iHub is an important part of Healthcare Improvement Scotland, leading the way in supporting improvement across health and social care, increasingly moving from working just with health boards, as it did in the past, to working with the integration boards and the health and social care partnerships. And it gives a flavour in both in numeric and in other terms of the nature of the work that's carried out in terms of our improvement activities. We keep coming back rightly within our organisation to trying to measure impact. And in some of our activities, it's easier than others. I've given you a whole lot of percentages in relation to the patient safety programme, and those are really important. But sometimes it's actually quite hard to measure the impact of what we do. When we had a presentation from Jo Matthews, who's been a major part of the SPSP for some time, at a recent board meeting, she came in and said she'd just come from a meeting of 300 people from the maternity safety programme. And you could say, well, what does that matter, a meeting of 300 people? If that meeting of 300 people didn't happen, there would not be the opportunity taken to spread the good practice which happens in one area and to transfer that into the circumstances of another area. So that sharing wouldn't happen if those people were not brought together. And you could say, well, that's a different type of measurement, and it's really important. So I do want to emphasise that. Back to anniversaries, and this time it's 25 years of SIGN, the Intercollegiate Guidelines Network. And if you want to know more about it, John Kinsella is sitting in the back row there. He's chair of SIGN and will happily tell you more. SIGN is one of a number of our bits of our honeycomb that get involved in our evidence work. So in addition to guidelines, and I will come back to SIGN, we look at standards and assessment of medicines, non-medicines technology, so that's SMC, SHTG. We also have a group called SAPG, the Scottish Antimicrobial Prescribing Group. Doesn't quite trip off the tongue. But it's really important because this week it's World Antibiotics Awareness Week. And a report published in 2017 demonstrated a significant, and 3% is significant, drop in antibiotic use in NHS Scotland over the last 4 years. In primary care, a decrease of 7.8%. That's a major public health issue. And again, it's a part of Healthcare Improvement Scotland. But let me return to SIGN. The important thing about all of this, I've mentioned impact, is that we don't just produce the information, but that we support the delivery of that. And I've tried to illustrate that on one particular, and again, somewhat busy slide. Glaucoma is the third most common issue that results in the risk of sight loss or blindness in Scotland, affecting over 50,000 people. And SIGN produced a guideline a couple of years ago seeking to improve referral accuracy and safe discharge of people. And what was important about this guideline was not just its production, but the follow-up activity which happened. And again, an important part of what we do is that we don't work alone with other national organisations, in addition obviously to working with local organisations. We seek to make change happen in as positive a way as possible. And in this one, NHS Education has been a key player because they were able to follow through the guideline with support and education for community optometrists so that the work of SIGN becomes real. And we're already seeing, and the impact, which is over at the right-hand side of that slide at the top, is already showing an improved accuracy and completeness of referrals from community optometrists to the hospital service, and a decreased rate of false positives. And the end result is better care for patients who have this really quite debilitating illness. So a real practical example of what SIGN does and the impact that it has. Why an iceberg? We're not the Titanic, you'll be pleased to know. At least we don't think we are. But it is important to look below the surface, and that's the obvious analogy here. And what we've been trying to do in 2017-18 is to think about how, as an organisation, we look below the surface and help others to look below the surface. And so what we've developed is something that we've called a quality of care approach. You will know that in the past our assurance activity has been done under a number of banners, and I'll come back to remind you about what some of those banners have been. But what we felt was important was to take a reflective look on what is it that we're seeking to do in that assurance work, and how can we do it in a more coherent and effective way. So that's what we've developed through the quality of care approach. As I say, looking underneath the surface, trying to design our inspection and review frameworks and provide external assurance in a way that really does support organisations and drive improvement. And when you look at it in this way, what we're trying to do is draw together the opportunity to look at board level reviews, hospital inspections, the things which are on that, but do them in a more coherent way than perhaps has happened in the past, so that we can take a more substantive and substantial view of what is happening across an area. And we worked with NHS Orkney to try this out in 2017-18. We've learned from that. We're now working with others, and this will increasingly become the way in which we undertake our assurance work. But I said I would remind you of the current and past approach, and these have all had significant value in Scotland. So you'll be familiar with the HEI inspections, older people in acute care. I want to come back to independent healthcare in a moment. The joint inspections of adults and children's services. And again, not least because Rami is here and has been a hugely important partner to us from the Care Inspectorate. And Paul is here somewhere. Where's Paul? He's over there. Paul is chair of the Care Inspectorate, sits on our board, and the chair of our board sits on the Care Inspectorate board. And that partnership is enormously important now in the work around integrated care. And those are two practical areas around the inspections of adult services and of children's services, where the two organisations work very closely together, again, to promote and secure improvement. And you'll see the numbers there. The numbers are important, but the impact, again, is what really matters. And perhaps a more recent one that not everyone may be aware of is working with the Inspectorate of Prisons, an area of real importance for that population, that enormously disadvantaged population, and trying to ensure that the healthcare and social care which they receive is appropriate. A number of ad hoc reviews, we do that at our own instigation or at the instigation of others. The evidence that we gather, the information we gather, will lead us towards undertaking ad hoc reviews. So the quality of care approach is intended in the future to encompass all of that in a way which brings positive results. I said I would return to the independent healthcare sector. Again, some folk may not realise that one of our functions is as a regulator. We are not a formal regulator in relation to the NHS, but we are a formal regulator in relation to independent healthcare. So we register, inspect independent healthcare services. And you'll see there just again some numbers. We've been inspecting and regulating independent hospitals and hospices ever since our inception 7-8 years ago. More recently, we've been given the responsibility to register and regulate independent clinics. And many of those are cosmetic clinics, Botox, etc., wholly independent, wholly private, dental practices, for example. So there are a range of independent clinics and an enormous amount of activity over the last 18 months in identifying those clinics and making sure that they are registered, and then we will be moving on to inspecting those, all with the same purpose of ensuring that the quality of care delivered is appropriate and that where improvement can happen, that we support that. So what we've been trying to do also, finally, in 2017 and right through the current year, is to try and draw all of that together into something which we've called a quality management system. You can use different ways of describing this, but this is our way of seeking to describe something which we believe is an approach which makes sense in our context in Scotland. It makes sense for us, and we believe it makes sense for the people with whom we work and the people we support. So it's the planning bit, which is about the needs, about trying to design services in a way which meets those needs. It's about supporting the improvement of those services where we can, and it's providing the quality assurance to supplement the internal quality control which the individual organisations will themselves has. And then, round the immediate outside, the importance of the relationships. And the relationships are with the people who provide services, but, and if I was coming back to the first slide, the relationships are with the people who use services. And that's about the co-design, the co-production with people who use services as well as the people who deliver services. And of course, all of that wouldn't work if it wasn't that we had a clear vision and purpose and the leadership, the attitudes, the skills, the behaviours which underpin all of that. So that's our attempt to try and describe what it is we do and continue to seek to do in the future. And I have to finish, as we always do in this annual review, with just reminding you that we consume a significant amount of money. As a national organisation, we have to demonstrate as much value as we can for that. Those are just the figures. What I've tried to do in the earlier part is to demonstrate some of the value which we believe we deliver for those figures, but we ought and we have to demonstrate to you how much we actually spend. But at the same time as spending the money, we also have to use it as efficiently as possible. So internally and with others, particularly the other national boards, we've been working to continue to secure efficiencies in cash terms and in reinvestment terms wherever we can. So my final slide, again, is many parts, one purpose: better quality health and social care for everyone in Scotland. Thank you.
Thank you, Hamish, and I personally appreciate you undertaking that task this year. Hamish talked about listening and learning, and as part of the preparation for today's meeting, we arranged for some of our non-execs to meet the Partnership Forum, the Clinical and Care Forum, and our public partners to ask them to discuss with us the progress and the challenges. So I'm going to ask each of the non-executives in turn to actually report back on the meetings that they've held, beginning with Brian Anderson, who's going to talk about his meeting with the Partnership Forum.
Thank you.
You're asking for trouble giving me a microphone. I might do one of my Elvis impersonations. I had a very interesting and useful meeting with members of the Partnership Forum. I had tried very hard over the last 4 years to actually attend a meeting, and it never worked for some reason or another. So it was something that I was particularly keen to get involved with. On the Staff Governance Committee, I have worked alongside Duncan, and he had given me some idea of what went on. But I was especially pleased to note that I felt we had a very honest and open dialogue at the meeting that I had. It was not only honest and open, but it was surprisingly positive. And I say surprisingly, maybe that's the wrong word. I wasn't necessarily expecting it to be positive or negative, but it was a very positive meeting. From my point of view, I felt that I got a much wider understanding of how things work within the Partnership Forum. I think that my full report is included in this document, and I don't intend to read the whole thing. I think the best thing will be for me to actually give the summary points, which I made at the end of that. And basically, there were 3 summary points, which partly reflected what had been covered in last year's review, because I felt it was important to notice what progress had been made from in that area. So the 3 things which I have summarised as being the key points from this report are, firstly, as I've mentioned, the positive contribution and constructive attitudes of the Partnership Forum representatives. The ongoing development of last year's 2 key themes. One was about values and behaviours, and the other one was about career pathways. The word that was used to me in describing the work that had gone on in the organisation on career pathways was exemplary. You don't hear that sort of remark very often, so I made a note of that. It was agreed that these were still sort of subjects that were in progress, that they had moved, that there were green shoots throughout the thing, that things were going in the right direction, but there was still a lot of work. And then I suppose there was a third point, which was a loosely sort of collected group of more general challenges to the organisation, which are specified in the report more particularly, but they're relating to staff relations in a rapidly enlarging and progressive organisation. HIS changes all the time, and that has to be reflected in the way that relationships work with the staff. And that's my report.
Thank you very much, Brian. Hamish, the Clinical and Care Forum?
Yeah, me again. I decided to pay a second visit to the Clinical and Care Forum because I'd been there last year, and it was for 2 purposes. One was just to pick up some of the issues that we talked about on a previous occasion, but also to think ahead. And we're changing as an organisation. We continually evolve, and inevitably we look to those that work with us to be part of that evolution. The Clinical and Care Forum in Healthcare Improvement Scotland is not the same as a clinical forum in a territorial board. It can't be, because we're not the same, and the functions are not the same. But they are similar in the sense that it's about trying to get a coherent clinical voice into the work of this organisation, and that is what we have been seeking to do. And I think we have gone some way. I think we've still a bit to do in terms of that involvement and that contribution. The Clinical Forum, you'll see from your pack, has a very significant number of players involved in that, both internal, but crucially from our point of view, external members. And I think we have a real opportunity to capitalise on that input. So we talked about some of the practicalities, about how we could do that even better in the future in terms of making sure about alignment of agendas, understanding of the future. But 2 things struck me. We have round that table, and it isn't always a real table, you don't get 100 and whatever number round a table, but you have that group of people from across Scotland who can tell us a lot about what is going to happen around health and social care in the future. And that horizon scanning can be enormously important. But one of the other things which struck me was the opportunity which they were taking to share across again. So that's about the sharing. I mentioned that earlier in my previous address. But that sharing of expertise, that sharing of understanding is really important. So those were two things which struck me very forcibly. A gap, and we should be quite honest about it, is we call it a clinical and care forum, and it is largely clinical. And we've tried, and we need to continue to try, to widen that so that the forum itself has that broader base and also can contribute in that broader way. But we did recognise that we do have within the organisation something called a strategic stakeholder advisory group, which kind of grew out of an earlier bit of our organisation, which at one point was called the iHub committee. But what we were seeking to do there was to capture a whole range of organisations with whom we now work, two of whom are in the front row, Scottish Care and the Care Inspectorate, in a different way. And I think one of the things which struck me was, what are the opportunities for that group and the Clinical and Care Forum actually to work together on issues, because they span the spectrum in a way that I think could be enormously effective. And then there were some practical issues about making sure that the organisation that we call the Clinical and Care Forum was as well known within our organisation, across the whole spectrum of our organisation as it could be. And finally, trying to think again, I keep coming back to impact. How do we measure the impact of that? Because people give their time to this organisation. They need to feel that that has value. So we need to measure that in some way. Thanks.
Thank you, Hamish. And our final piece of feedback is from our public partners. I'll ask Kathleen Preston to present the findings.
Last week I had the pleasure of meeting with a group of representatives from the Healthcare Improvement Scotland public partners. Now, public partners are volunteers, they're citizen representatives, lay representatives, who work across a wide range of our activities within the organisation. And I would like to thank all those who participated in the meeting, but more widely, all of our public partners who give up their time on an entirely voluntary basis to support our work. This can range from participating in an inspection of hospital services, where one of the vital roles of the public partners is obtaining feedback from patients and families. And Hamish spoke very strongly about the importance of the public voice in our work. And this is a very important aspect of the work. And I would like to say that public partners are a very valued part of our organisation. And we would like to thank them very much for the time and the effort which they put in to our work. The discussion ranged on picking up from outstanding issues from last year to moving on to the more general concerns and suggestions that our partners had. I think it's probably important to highlight that the majority of the public partners who participated in our meeting are new or relatively new to the organisation, so it was helpful to get their perspective on the work and what they've encountered. The first point I would highlight, which was raised last year and is ongoing, is clarity of the role of a public partner. It was clear throughout our discussions that there were differing views as to what that role was. So I think we perhaps have a little bit more work to do just to make sure that we have a shared understanding of what that is. The second important point, which is really fundamental to the work of the public partners, is their involvement in our work. It became clear from the discussions that there is a difference in the way in which different parts of the organisation involve public partners. That's inevitable because of the range of the work that we do as an organisation, but it is perhaps something that we should reflect on a bit more. Some of the public partners who were at the meeting said they were very involved in various aspects of our work, and they had a lot of support from the chairs or the leaders of the work programmes. there were other aspects in which they felt less involved. One was the iHub, and I know that that is partly in relation to the context of the iHub and its involvement of stakeholders, but again, it is something perhaps we need to reflect on. And generally, that public partners do need to be supported administratively in other ways when they're involved in our work. And the final point that I think I would highlight is the fact that our public partners come to us with a vast range of experience and skills which they have gathered in, I won't say their previous lives, but generally through their background. And there were issues raised as to whether we were correctly and properly and fully using those skills and experience for the benefit of the organisation. There was an issue that we don't want people to come with preconceived ideas that they have from previous professions or work, but actually it seems just only common sense that we make the best use that we can of the skills and experience of our public partners. So all in all, it was a very useful and enjoyable afternoon, and I hope that the public partners who attended would share that view.
Thank you, Kathleen. And actually, there are quite a number of public partners in the room who've kindly joined us today, so it's really good to see you all. We're now moving to take questions from our guest reviewers. We've invited a number of people to and given them the opportunity to actually ask questions. So can I begin with Rami, please? Would you like to kick off?
Thank you very much. I'm Rami Okasha from the Care Inspectorate, and I suppose the first thing I wanted to say actually was just to reflect on, during the course of the year, as Hamish said, the continued very productive relationship between the Care Inspectorate and Healthcare Improvement Scotland across all areas of work around scrutiny, improvement, knowledge and so on. I think the relationship has matured and developed, and both organisations are able to add value which is greater than the sum of their parts actually into the system, which is helpful. So I really had two questions, if that was okay. The first was around learning, and it struck me when reading about and hearing about and knowing about the quality of care approach is that gathers a huge amount of evidence about what's working well and on occasion what's not working well and what needs to improve. So my question is, how can we collectively do more to get that knowledge and learning back into the system? And it strikes me that the Scottish approach of combining scrutiny and improvement in one organisation gives a prime opportunity to be able to use some of that evidence into learning. So that was my first question.
Okay, so we'll take that one first. And are you going to start?
Yeah, I'll kick off on that. I think, can I just deal with the point you said at the very start, Rami, about the maturing of the relationships? I think it has been extremely positive, and I think we should put on record your contribution to that, Rami, yourself, and the work that you've done, which has been extremely positive. In terms of the learning system, I think there's two bits to this. One is about how do we actually scale up and spread more quickly and at pace innovations in Scotland. So if you were to go to the Audit Scotland report that was published today on integration, there's fantastic examples right across Scotland, but not universally implemented. So there is something about how we work on that together as both organisations. So there's immense work there. But the other bit I would say, just in the context of improvement in inspections, is inspection does lead to improvement. So if you look at where we were with Aberdeen City a year, 18 months ago, and the number of delayed discharges, concerns about adult support and protection, and the most recent inspection, you'll see considerable improvement. So I think that's something we just need to reflect on as well. In terms of sharing good practice and intelligence, there is scope to do more, but I'm really proud of the work that's been done so far around the Sharing Intelligence Group. And I should say this question and answer session isn't just from me. I've got an whole executive team there who are going to help me out. At that point, Brian, do you want to talk about sharing intelligence?
Sure. So I'm Brian Robson. I'm the Medical Director at Healthcare Improvement Scotland, and I co-chair the Sharing Intelligence Group that brings together 7 national agencies, including the Care Inspectorate and Healthcare Improvement Scotland, to consider the published reports from each of those agencies. So Audit Scotland would be around the table, as well there. And what we have done over the last year is that when we review an NHS board, we particularly look for examples of good practice, and we put those examples back to the board when we meet with the board after we've discussed their reports at the Sharing Intelligence Group. So particularly just trying to highlight to the boards, because oftentimes, Rami, when we give a view externally to the Chief Executive and say that this is good practice, the Chief Exec doesn't actually know that it's good practice, not through ignorance, if you like, but just that's the way they do things in their board. So they, like you, are looking for what is the mechanism that we can share this more, share the good practice more. But certainly this year at the Sharing Intelligence Group, we focused more on the positives as well as the areas for improvement. Yeah.
And you had a second question, yes?
I did. Robbie touched actually on the Audit Scotland report this morning, and I guess in one sense it echoes some of the findings from our joint inspection work, which is demonstrating that in some areas the pace of change and integration is faster than in others. And in one sense that's quite understandable. This is a huge change and will take time to bed in. And there are different cultures between health and social care that need to be thought about in the context of integration in order to be able to make it happen faster. But I suppose my question is, what more can HIS and the Care Inspectorate and other organisations do together to support that integration to take place where change isn't happening fast enough?
Okay, I'll have a go and then I'll maybe hand on to Ruth. So one of the things, and one of the stark messages within the Audit Scotland report today is that the shifting the balance has been static between institutional and community care. So it's between something like 54% institutional care combined between health and social care, and 46% in community. So that reflects a number of things in terms of culture. It reflects quite a few things about strategic planning and commissioning of services. So what we've been seeking to do with a range of partners is start to strengthen that whole approach to strategic planning of services and start to move to different models of care. Now that comes back to about how do we share good practice, but Ruth, you might want to say about work in terms of strategic planning, for instance, in Orkney or elsewhere.
And it actually relates, I think, Ruth Glasper, Director of Improvement for Healthcare Improvement Scotland. It relates in part to your first question here about how we support that spread of good practice. So, for instance, we've had an improvement programme for the last 2 years, Living Well in Communities, very much focused on working with integration authorities around how can we support the good practice that enables people to live well in the community, to avoid hospital admission, or where they are admitted, to then be supported to live back home. A lot of that work to date has been prototyping work. So we've been working with, say, 3 or 4 partnerships, testing practice. We are now at the point where we are moving to scale up across Scotland, and using the same approaches that we've used so successfully in programmes such as SPSP, around being really clear that you don't change practice just by telling people to do something different, and also being really clear that context really matters. So what works well in one area, you can't just take and implement it in the same way. So we are putting in place at a regional level the learning networks where we'll be pulling people together. We've already started in the north with a real focus on frailty, to support them to look at what works and then to adapt it into their local context. And that adaptation is really important because it has to be fit for practice locally, but at the same time, we don't want to be in a place where every area is learning from scratch. So it is trying to get that balance between what's worked, making sure that the folk who are going to be implementing it know about it, but then practically supporting them to implement that change.
But I think it is a really significant issue. You know, we've been talking for longer than I can remember about how we bring health and social care together. We can find good practice in certain places, and perhaps when we get to the wider questions, we can come back and have a bit more discussion about this. And some of you may hopefully have some ideas and thoughts about how we might, increase the scale. And I'm going to come to you, Susan, because I suspect this is a theme that you might want to continue to pick up.
Thank you very much. Thank you, Carol. Yes, absolutely. I think probably the questions I was initially going to ask have already been asked, but let's develop
Tell
that.
people who you are.
Yeah. Yes, let's develop that a little bit further. I mean, you know, I'm interested in what you were saying there, Ruth, about things can't be just globally transferred, but in a lot of ways the fundamental ideas can, and I think that is part of the problem. We don't grasp universally the need for change. It's been, as it says in the Audit Scotland support, is static, so that we need leadership around best practice and actually implementing ideas that make things really person-centred. So the nub of the idea, like, you know, Jason Leach is here today, he could stand up and talk to us about continence care, couldn't you, Jason, wherever you are? And you know, that's an idea that we could universally take, you know, that if we actually introduce decaffeinated, all fluids being decaffeinated in care homes, you will dramatically reduce the continence issues that you might have in that care home. But that's not something you just go in and enforce on people. You go in and you talk to people in a person-centred way. You have conversations that actually talk to people and families and carers about self-management and rights and responsibilities in the same conversation. So how do we actually shift that culture? We're in this static pool where the leadership has not been working around that. So how do you, at HIS, offer that development? You know, you've got it in your strategy. Page 10 of your strategy talks about a better quality for health and social care for everyone in Scotland, and you break that down into very readable, very understandable chunks. But this is clearly not making its way from this page 10 of your strategy, into those conversations with local leaders, and then disseminating down to the leaders of their own care, who are the people. You need to have these real people conversations with them and with their families to make things different.
Okay, can I start on that? Because I think the essence of what's been said there is about human rights and the extent to which we're actually taking a human rights-based approach within healthcare improvement in Scotland. And I'm going to bring Sandra in a moment on that in terms of more broadly the work we're doing. But if you take self-directed support, for instance, and what are we actually doing to make meaningful choices out there, and how do we in Healthcare Improvement in Scotland, working with the Care Inspectorate and other partners, the Alliance and so on, actually make that more meaningful and actually not just business as usual, but actually a different model of care, then I think that's starting to change in how we work as an organisation. So on that point, I think there's a big bit of work that we're doing in the organisation, but the other bit around actually good practice and best practice and how we disseminate it, there's frankly a bit of protectionism about models of care and the extent to which what happened over there can never be replicated. I take the point about context, but that's an excuse too far at times. But Sandra may wish to come in terms of the work around human rights more generally.
Thanks, Robbie. I'm Sandra McDougall. I'm Acting Director of Scottish Health Council. Yeah, we've been doing a wee bit of work in the organisation over the last couple of years, thinking about how can we introduce a human rights-based approach to the work that we do. I think traditionally our focus as an organisation has been more around equalities, and I think that's probably reflective of NHS boards as well. There's been an awful lot of work around equalities, equality impact assessment, and how we implement the duties that exist across the NHS. I think probably there's been less focus in the NHS than there has in social care services around human rights, and I think there's huge potential around that. I think we've been doing some work with the Scottish Human Rights Commission initially to think about the panel principles, which some people will be familiar with, which are a kind of simple framework, which I think are really helpful in terms of us having a common language across health and social care, which is very much focused on people and the rights of people and of staff within services. So we've been testing this approach of panel. So I'm going to try and remember what panel stands for, because it's an acronym. So participation, accountability, non-discrimination and equality, empowerment and legality. And it provides a sort of framework that enables you to look at things through the lens of individuals and what things mean to them. So we've tested that on a number of pieces of work that we've done, and we think there's real scope in us using that. And as I say, I think one of the big benefits that I think there has is to try and get away from the different use of language within health and social care. So there's lots of similarities across health and social care in terms of things like personal outcomes or shared decision making, but we use different sets of language often to achieve the same end. I think focusing on people's rights gives us an opportunity to get away from that and to use a language that's common right across the public sector and make sure that we are keeping people, and that's people using services, their carers, and also staff at the heart of what we do. So we've tested some training for staff and the use of the panel principles, and we've just rolled out some guidance and offered some awareness sessions for staff. So we're in the early days of implementing the human rights-based approach. But I think one of the things that's been hugely important around that is the national standards for health and social care, and the Care Inspectorate and ourselves have been involved in supporting the development of those standards, and those standards are very much take a human rights-based approach and start from the perspective, all the statements are framed around what matters to people and what people should rightly be able to expect from services to enable those better conversations to take place.
Thank you.
Can I make
yes.
Can I just make a comment, Susan, if that's okay?
Yeah.
I don't think we should duck the issue about what is it in a particular area that actually makes a difference to the implementation of integration in a real sense that makes a difference to me as an old person, he said, feeling old. But it doesn't happen next door in another authority. So when we identify that, what are those barriers? And so what is it as an organisation we can do? And not just us, because we can't do all of this on our own, but identifying those factors and then working with that organisation to identify those factors and working with the leaders. And I'm talking about leaders at the top level as well as actually making it happen. If you don't have a culture from that top level that really believes in what we're trying to do and who are protective, bluntly, of their own bit of the system, then it ain't going to happen. And I think if we just pretend that doesn't exist, then I think we're fooling ourselves.
I think what you said just right, from the evidence from research looking at partnerships that have worked, where integration has worked and where it hasn't, and where people have come together, the evidence is largely, it's about the people and the leaders and the people in the senior positions. And if they build positive relationships, work well together, they create that sort of culture. And too often, sadly, we can all think of examples where people spend too much time defending their budgets, defending their territory, talking about this is mine rather than this is ours. And lots of the issues, let's be honest, around IJBs are about people spending too much time having territorial wars rather than saying this is, we should care about the community out there.
And that's where I feel that his is in a really good position to actually try and influence that that area and try and introduce an understanding of what is it like on the ground, on the in a care home at the end of the street, in a local community hospital that are trying to deal with a whole complex range of people that come in, and people are untidy and they're messy. Their lives are unravelling before us, as they come to us as frail older people or as disabled people where their care package is perhaps breaking down for whatever reason. And we need to be able to look at them, as real human beings and actually find out what they want in their lives in a way that fits in with this leadership approach, but actually just lets them have those messy and untidy lives. We can't make it all pretty and absolutely perfect. And that's what I meant by my original question about the education of the public as well around their rights and responsibilities, because it's not that we can't possibly, as a Scottish country, say we'll care for everybody, we'll provide 24-hour care with no holds barred. We know we can't do that. But also that's not an answer that we want either. It's how do we actually really offer community-based care And that's about people's own homes. That's about us actually building services in localities and actually building networks between all the sectors that are there to support people in a way that's actually effective. So, you know, that I think you're absolutely right, Carol and Hamish. That leadership area, I think, is somewhere where you can make a real impact in HIS, and I would support you and encourage you to do that.
Okay, can I move on to Karen then from Scottish Care? There's sort of logic to these links, I think. I hope.
Hi, thank you. It's Karen Hedge from Scottish Care. I guess I'm going to slightly wing it here, since we've just been talking about a subject close to my heart on integration. And absolutely I agree with what you've been saying around about leadership and culture, but there's a real need to have a holistic viewpoint about what integration means. And often what we find as an independent sector representative, and that's independent sector which is private, voluntary and charitable, is that we're sort of last in on that conversation. Now, it was really interesting to hear what Rami was saying about the relationship that HIS has with the Care Inspectorate. And we're not in the same position, Scottish Care is having that, but we are on that journey, and I really appreciate that, and that HIS is able to think beyond that and think more widely on that. But we would absolutely welcome the ability to have more conversations and more involvement at that senior leadership level, in the same way that we have with partners such as the Care Inspectorate, COSLA and Scottish Government. So I think that is possibly a route towards improving that. And being able to share some of that information that's happening locally, particularly around what you're saying about the clinical and care group earlier, Hamish. So, yeah, hopefully that will be helpful, and I look forward to being engaged in that further. You also sort of headed me off on the past, because one of my questions was going to be around about the citizens panel, but I might just pursue that a wee bit further, because one of my questions is about how do you engage the disengaged or the hard to reach in that?
So that's absolutely fundamental in terms of our thinking about, and what Hamish said earlier was that we can't see engagement solely through the lens of the Scottish Health Council. It's fundamentally important right across the threads and the different dimensions of healthcare improvement in Scotland. But Sandra, you might want to say a bit more about that work.
Yeah, the Citizens Panel was developed linked to the Our Voice framework, which is about looking at how do we strengthen the voices of people at different levels of the system. So at individual level in terms of their own care and treatment, at local level in terms of the services that they use, and also at national level. So the Citizens Panel is one way in which we've looked at how do we hear people's voices at national level and national healthcare issues. And I have to stress it is only one mechanism, and it's certainly not intended to be the only mechanism. Just to explain a wee bit about what it's about, we wanted to have a mechanism that would enable us to get a sort of voice of the Scottish public, in there, because we wanted to get a broadly demographically representative sample of the Scottish population. There are lots of mechanisms for hearing people's voices and lots of organisations who represent particular interests, but the sort of general public voice, how do you get that? So this is one way of trying to reach that. So we recruited people from across Scotland in every local authority area. We used different approaches to try and get that broadly demographic profile. So we used some random sampling through the electoral register, and then we looked at who was responding to us from there and what demographics were missing, and then did a bit of targeted recruitment around that. So there's a report on our website which explains the kind of approach and methodology that went into that. Did we succeed in getting a broadly representative sample? Partly. There are some areas where we have a slight imbalance, so gender is one of them, where we had slightly more females than males, and we have to think about what that means in terms of people responding to us. So we engage with the Citizen Panel through surveys. We've done surveys on a broad range of subject areas. Again, the reports are all on our website. And what we do is we look at who's responded to the surveys. Not every panel member will respond, and we look at where maybe demographics are a bit shorter and target those panel members to encourage them to take part. We've done 5 surveys so far. The big question is, as Hamish has talked about earlier, is impact. You know, what difference is it making? And for panel members, it's really important to see that their views are making a difference. So we've got now beginning to see some examples emerging of where panel members' views are being used to shape national policy. I suppose the question then, if you take it to the next level, is, and what difference is that policy making in practice? And we've not quite got there yet. We've just been evaluating the panel and looking at how we might reshape it for the future and refresh the membership. So it's a timely question. What I would stress is it's not a route to hear everyone's voice. So people will sometimes approach us and say, we've got an idea, would like to ask some questions to your citizen panel. And we have to encourage them to think very carefully about, well, who is it you want to reach, and how do you make sure that you're hearing voices that might otherwise be missed. And the panel is only one mechanism for doing that. So on the national issues, sometimes we complement the work that we do on that with some targeted engagement through our local office network. So we have a local office in each health board area in Scotland that's got really good links with communities. So we'll usually through our community contacts and links with third sector organisations, if we want to make sure that a particular voice is being heard, then we will work in partnership with them to make sure that happens. Sorry, that was a very long answer. I don't know if that's actually answered your question, but I hope it's been helpful.
Especially from someone who spoke so strongly in human rights, then that's very reassuring. Thank you. I have another question which falls out of the work around about ACPs, and I'm really pleased to hear the stats on that, and really pleased to hear that more people are having an opportunity to die at home if that's what they choose. My question is about what happens in terms of reviewing the implementation of a project or an idea further down the line, because sometimes projects have perhaps unintended consequences. So one of the impacts that our sector is seeing as a result of ACPs is our frontline workforce are now delivering more end-of-life care. And this year, Scottish Care released, earlier this year, we released a report called Fragile Foundations on the mental health of our frontline workforce. And for instance, one of the quotes was around about a staff member pulling out of the car park, pulling into the next lay-by and crying. So there's a real need to offer some extra support there for those staff that are now finding themselves in those situations. So that's just a sort of a live example of where other people are sort of picking up on what is a great initiative. And I really want to stress it is a great initiative, but what systems does HIS have to review things further down the line when those sorts of unintended consequences happen?
Okay, I'll start on that. So one of the big bits of Healthcare Improvement Scotland where we need to put more time and effort in is evaluation and learning. So if you go back to the learning system, at the heart of that is about how do we share and spread good practice, but also how do we have the candid analysis and evaluation of our work and ensure that that is disseminated and we learn from that. So that's a big bit of what we have to spend more time on. And we can take learning from the Scottish Patient Safety Programme. For instance, how did we actually embed that into the system in terms of our bundles and model of improvement, and then how does that learning then apply into a broader context of health and social care. So things learning we can take from the positive, but also where we can do even better. But Ruth, do you want to say something about evaluation more generally?
Yeah, and I think tying it back actually to the work around strategic planning, because this is absolutely key. And our strategic planning work that we're doing with the IJBs is very much around supporting them to understand the needs of their populations and to understand the assets of their populations, and then to redesign the system of care so it meets the needs but also makes best use of the assets. And the assets are inclusive of individuals, their communities, the third and independent sector, which are a key asset that we often don't make enough use of in a positive way. And so I relate that back to your question in as much as if a system is set up in a way that's doing that, When you implement something such as ACPs, and you then find that there is a consequence on another bit of the system, it's about then that ability to understand that and then think about, so what do we now need to adjust and do differently so that we are then addressing that unpredictable consequence. We have a role in the work that we're doing to highlight these issues with the system, and that's something we can work with you on as well in terms of making sure that if this is an unintended consequence of work we've been doing, that we are highlighting that, but also then to help to think through, so how do we best respond to that? And I think it's that weaving together of the local response and then the role we have in capturing and sharing the key learning across the system about how to respond to those issues. We are looking at the moment about how we strengthen our resources, both about capturing what's working, but also this issue about the evaluation part of it, because sometimes something that looks good on the surface, when you do an assessment, is not actually as good as you think it is. So we had 2 initiatives over the last year that we were asked to spread. We started off by doing a spread assessment, so we went in to have a look and say, is this something that it would be worthwhile spreading? And in both cases, the conclusion was no. One, just as a practical example, it was a great improvement in that local area, a 20% improvement in an issue, but actually they were outliers. They were starting from a very poor position, and when we did the assessment, we were able to show the rest of Scotland's already doing better than that, and the things you've implemented, the rest of Scotland's already done. So there is something for us about, we're now looking at how do we strengthen our evaluation, but how do we also strengthen this ability to go in and do these spread assessments so that we can then be clear on which of the things we should be spreading across the system and which of the things actually we just say good work, but it's for local work.
Okay, and our final guest reviewer is Margaret, one of our public partners.
Okay, thanks very much. First, I'd like to say thanks to Kathleen for the comments that she made about public partners. Unfortunately, I wasn't able to attend the meeting, but I did gather the information from the people who did attend, and that was shared with us. So that was really reassuring. From my own perspective, I'd like to say I feel that I have been supported and I have been valued by Healthcare Improvement Scotland. It's not been easy because of the honeycomb and all the different things that are around there. And obviously every single public partner is different, come with a different set of skills and experiences, as was mentioned. And I think what I've tried to do is capture what I think the sort of key questions are for the current public partners. And I think particularly when you're a new public partner, it's even more daunting. But I think certainly my experience has been people have been really helpful at being supportive, particularly when you're dealing with things that are completely alien and unknown. So my first question would be, how can public partners be better supported and developed to ensure that the public voice is heard when participating in new areas of work? For example, the quality of care review. I know that we're about to go into the next phase of that, and I think it's really important that people do have a good understanding of how they take that forward.
Okay, well, I'll start with that. So firstly, thanks very much for the positive feedback and at a personal level, your contribution, what you brought to the organisation. I think the first thing I'd say, and going back to Kathleen's feedback, is that the experience for public partners isn't always consistent when they come into Healthcare Improvement Scotland. So what we're seeking to do is to make sure that that experience is consistent irrespective of where you are. Now, the work will be different in that honeycomb and different things you'll be asked to contribute to, but the overall experience, the induction, the support, the documentation, the communication, the sense of involvement should essentially be similar, identical, wherever you engage. And secondly, on the point about working with external partners, is that's increasing. So we're doing more and more, not just with HIS, but external partners. So that experience for public partners should be the same as well in terms of whoever you engage with in coming into HIS and then relating to others as well. So we've got work to do to make sure that compact between HIS, myself as the Chief Executive, with public partners is consistently applied. And I think that's a big message about how we do that on a day-to-day basis, because some of the niggles that do get in the way, some of the difficulties can be really off-putting for public partners, and it may just be something about, you know, a piece of documentation on the screen and how am I going to print that off. And so there are things which are really, really important, but there's stones in the shoes that get in the way of that experience. So very much hear that message, more work to do, but fundamentally we can't do the work that we do in HIS without our public partners. They're absolutely central to everything we do.
Before I would move on to the second question, I think one of the things I was encouraged by today, and I'll make a plea for public partners, you particularly mentioned, other people have mentioned about sharing best practice, and I think that sharing best practice approach should be applied to public partners as well, and given more opportunities for learning. Because I think that whole bit about how people can be better supported, it's the getting beyond the niggles and the, you know, the printer not working and stuff like that. But it's about making sure that people feel comfortable with the things that they're dealing with, because a lot of the terminology is very difficult to get to understand, particularly acronyms. I suppose the other area, and it's been touched on, is about the recruitment of public partners. Are there plans to adopt new ideas and innovative approaches to improve the reach of the recruitment of public partners from hard-to-reach diverse groups?
So a lot of work has been done on that in terms of improving the diversity of our public partners. It's a big time commitment, being a public partner. We recognise the demands on that, but we need to make sure that we respect the diversity of Scotland as a country. So Sandra, do you want to say a little bit about that work?
Yeah, thanks for raising it. It's been raised before, I have to say, and we have made efforts. So the recent recruitment exercise, we went out very proactively and engaged with organisations who represented different interests to speak to them about the public partner role, to get their thoughts around that, and to ask them to help us to promote the opportunity to get involved. That didn't result in the sort of success that we had hoped for, but we had a lot of really useful learning from that about what matters to people, about sometimes some of the things that get in the way for people, about the expectations that might be placed on them in terms of some of the volunteering roles. Some of our public partner roles are quite challenging, quite time intensive, require quite a big commitment, and for some people that isn't appropriate, but there was a willingness for them to get involved on a more ongoing, informal basis in terms of some of the work that we do. So I think we've had a lot of learning from that and built some good relationships. But I think it's partly about what was touched on earlier, is about the role of public partners and getting the role right and having more flexible roles in there, because, as I say, sometimes the time commitment that's required can be a challenge for people. You know, being involved in inspections and reviews, for example, can be a big commitment from people in terms of time and the opportunity and the time to get involved. You know, if that's happening on a Monday to Friday 9 to 5 basis, then that doesn't necessarily suit people's availability. So we need to think about more flexible ways of getting people involved in that. As I say, useful learning from the previous exercise, but we haven't quite cracked it yet. So I think if our public partners, particularly those who are new into the organisation and are having their own experience of joining and reflections on that, can help us with that when we go out for our next recruitment, then that would be very much appreciated.
Across both questions, really, I suppose one of the things that I would want to just touch on, just as a follow-up, is what about mentoring? Has that been considered? Because I think there is a scope for that to help in terms of supporting public partners, and also maybe it'll help in terms of recruitment.
That's a really good idea. I think there's a lot in that, and about support and bringing people on and developing them, so take that away. Yeah.
And you could think of using it, I mean, I suspect a lot of the public partners are people who are at a certain stage in their lives. Yeah. But if we actually recruited and encouraged people at earlier stage in their careers in their life, some of that mentoring could actually be help in terms of developing skills that they could then use in other settings. So there'd be a byproduct. We'd get the benefit of their participation, but we'd actually be helping them into employment, for starters, you know. We could support the young people into work initiative, you know. So so we're thinking about it. It's a good idea. Okay. A big thank you to our guest reviewers. We asked a lot of you in terms of coming and asking questions for us, so I appreciate that. I picked up some themes from those questions. There was something around spreading good practice and scaling up learning and moving away from, you know, just having projects and good practice in isolated places. Something about leadership and what HIS might do to actually support better leadership, particularly in terms of moving integration forward. And then something about participation, how we can widen the network and how we can reach the people that we don't actually reach, you know, rather than just the usual suspects, because that is quite important. And I'm sure there were lots of other issues floating around there, which we can pick up as we open up the discussion or move on to different topics. It's now open to your questions. Yes.
Thank you. Jim Findlay, public partner. In the interests of transparency, I'm also a councillor with the Gowan Butte Council, but I was a public partner before I became an elected member, so just get things in the right sequence here. My question, or my observation actually, is related to leadership and change in culture. Prior to becoming a public partner, I worked for, now on 25 years, for W.L. Gore & Associates, an American-based company who had an early history of empowerment and leadership cultures. And to change any culture, you should not underestimate the investment, financial and money, required to free people's mind space to adopt any change in the culture. And I think that we would need to give leadership, whoever leadership is, the training, the tools, perhaps more importantly, the awareness and the mind space of their current behaviour to change and adopt a new or change an existing culture. So we shouldn't underestimate that. Thank you.
Absolutely, and I think it was perhaps less of a question, Jim, but more of a statement. But if we're going to have more influential leadership, then it is something different in terms of what we're actually looking for from our leaders of the future, because we haven't got one culture, we've got quite a number of cultures that we're trying to navigate our way through.
And the other thing I'd say is, if we're genuine about integration, stop training and developing your leaders in silos, because the more they're exposed to each other and the more they, you know, understand where each other are coming from and make the space to move towards each other, the better. There was a question over there. Yep.
Hello, my name's Pauline Warsop. I'm one of the new public partners. Two very big comments and then a bit of a question. In terms of public partners and initial training, if you imagine that you personally were dropped into the middle of Japan 300 years ago, you couldn't read the writing, you couldn't understand the language, and you had to get from the south to the north. That's how much support we need. Personally, for myself, my brain shuts when it's anything to do with computers, so I've had a lot of lovely support there. Second thing, it's a bit more of a comment towards Sandra and the Fragile Foundations thing. I take on board the fact that the front key workers, whatever you call it, need emotional support. My personal experience being in the hospice for as long as I was that also the cleaners and the porters are a main part of dealing with me on a day-to-day basis, and at that time they had no emotional support at all. And if you think about it, they're the ones that possibly meet with end-of-life patients the most, because they work 9 to 5 every day and the nurses work shifts. So that was just another comment. As a public partner and in my region, the worry that I have is that my local, Freudian slip there, my local NHS authorities, both have to find millions of pounds worth of cuts. Now, I totally accept that you can become more efficient and that will save money. However, again, my personal experience of being in hospitals and departments is that the nurses and the doctors are overstretched already. And it really concerns me that my area is having to lose over 1,000 employees. My personal suggestion would be you need more ground floor staff. I don't know enough about management, but as a member of the public, I would say get rid of your management and hire more nurses. So that's my opinion. Thank you.
Are you listening, Jason? I think your comments about what it's like to be a new public partner are really, really helpful. And I think probably there's a lot of people in this room who can think of circumstances they went into for the first time and were greeted with language or with acronyms, you know. So, but I loved your description. I think, where's Ken? We must use that at some point because it you know, captured brilliantly. Yeah, yeah.
My name is Ian Buchanan. I'm a public rep on the West Lothian Integration Joint Board, and for my sins, I'm now one of the new members on the strategic planning group that Hamish was talking about. I've got a comment and a question. My comment is that everything I've heard this morning is excellent. Support, like to see. It is a world away from what an IGB is discussing in its agendas, or what the strategic planning groups or locality groups are having to deal with on a monthly or 2-weekly basis or whatever. We're having to deal with cuts to drug and alcohol services. We're dealing with an almost open-ended expenditure on learning disabilities. We're trying to deal with a primary care crisis, and we have. In West Lothian, we did some excellent work in needs assessments in terms of older people, mental health, physical disability, learning disability, drug and alcohol. I spend a lot of my time actually trying to see whether any of these good things are actually going to come to fruition. Most of the bad things seem to be happening now, and most of the good things seem to be planned for a few years away. So that's my comment. My question relates to participation, to involvement. IGBs have, in addition to professional members and in addition to health board and councillors on them, they have statutorily, they have representatives from carers from carers, from the voluntary sector and from users. Now, I'm a user rep. I don't want to make any comment about users or public participation, because these subjects have been covered. But I'm thinking in terms of the voluntary sector and the carers organisations. There are 32 TSIs, third sector interfaces, in Scotland, one for each of the IGB areas. And a lot of the reps will come from within that organisation or have some association with it. Same with carers. The point of having carers reps or voluntary sector reps is to make sure that carers have a voice and that voluntary sector has a voice in the planning and organisation of future services. The trouble is, there's an issue that I think is going to come to fruition maybe in the next few years, and I'd like somebody just to give some thought to it. It is that more and more we're commissioning services, and some of those very care organisations or voluntary sector organisations that are also sitting on the IGBs to be a voice for carers or the third sector are also being commissioned. And I think there is the possibility of a clash of interests occurring at some point in the future. I just want somebody to give some thought to that.
Okay, I think that's something that Scottish Government colleagues may wish to take away in the context of the ongoing review of integration and the joint work between Scottish Government ministers and COSLA. But there's a broader agenda around that, certainly. I think the putting aside the issue of interests and representation of interests around that table and potential conflict, there is, though, mixed messages about the level of involvement of users in the genuine involvement, meaningful involvement in the preparation and design of plans for the future within IGBs. And I think that comes out not just about the quality of strategic planning in the Audit Scotland report, but meaningful and genuine engagement.
Can I pick up your first point? Because I don't think, we've had two comments about resources, and don't want you to think we're ducking it. I think there clearly is an issue about resources, but the other side of that, I think, is part of the drive for shifting care is firstly because that we believe that will be better for people, that actually being cared for at home, cared for in the community, more personal care is right. And there are resources tied up, particularly in acute hospitals and elsewhere in the health service, that people are looking to shift towards that community-based care and to avoiding some duplication. So there is some resource that's not being used as well as it could be, I think, as well as there not being enough. So there's a mixture of that.
Partner, just to go back to HIS, we've heard several times this morning about the honeycomb, and the honeycomb's got quite big, and sometimes honeycombs get sticky, very sticky. And I just wondered if HIS, given all the wonderful things it does, is maybe trying to do too much, in the sense, should it be focusing more?
Well-timed question, a very pertinent question, and my executive team are just nodding their heads vigorously at this point. I think what that honeycomb does demonstrate, though, is an aggregation of asks on us as an organisation. It doesn't necessarily tell us where we want to go in the future. So one of the key tests for us as an organisation is how are we meeting the Cabinet Secretary? There's new Cabinet Secretaries. 4 key priorities. So a lot of work is now underway in the context of our work and planning for the future about how can we deliberately demonstrate that we're meeting those. We're already doing work in mental health, but what are we doing on waiting times? So and we're doing lots of work on integration. So that then starts to introduce some difficult choices about how we spend the 30 million that comes to us each day. Each day, I should be so lucky. Thanks, each year.
You wish.
Each year. Freudian slip. And I think that gets to the heart of a big issue for us as an organisation about our confidence to express what the priorities are as opposed to receive things from on high. So that's a big agenda for us. So we come back next year, and I'd like to be talking about a refocused programme of work for the future.
Can I just make a comment about honey? It's wonderfully health-giving as well. I particularly recommend that from Mount Hymettus in Greece. I don't sell it, by the way. I just treat it. But if you'd looked at that honeycomb, it's really to go on to Robbie's point. If you'd looked at the equivalent of that when Healthcare Improvement Scotland started, it would look different because there have been bits added to the honeycomb. And I think one of our issues has been how is that appropriate? And sometimes we are the right organisation to take things on board. The reality is we try, as part of the bigger system, to do what we can to support that bigger system. So sometimes we take on responsibilities which are for the good of the system as a whole, and we then try and make sure that they are done in a way which is as effective and efficient as possible. That doesn't take away at all from what Robbie has said, because around the board table, that's what we have talked about, particularly over the last year or so, is how can we refocus some of that activity, accepting what we've got. What do we do with that in a way which is most effective? And what we didn't do so well in the beginning was see the linkages between all of those bits of the honeycomb, so it didn't taste as good. Sorry for the analogy, but you know what I mean.
Perhaps next year you could have some from the Scottish Government giving a wee talk about what they expect from HIS, because they seem to vacillate all the time.
And can I draw? We're trying to get better at explaining what we do, and if you can, I draw your attention to the description. Can you? They're sort of boxes. They in our other publications they come across as a box, a rectangle, but that's us trying to, if you like, capture the honeycomb in a slightly different way. Ken would be upset if I didn't draw people's attention to that.
Yeah.
Good afternoon. My name is Eileen Wallace, and I am a public partner long time. I'm one of the little bees that populate all of that honeycomb. I've buzzed in, I've buzzed out, I've done inspections, I've done reviews, I've done antimicrobial. I sit within SIGN, and I'm very happy to sit. I now sit on SIGN Council as one of the public partners. Long term, there are very few of us left. I'm now at that age and I'm about to go, but it's just a thought for Sandra as well. It's not only the new people that need support. We're very happy. We used to be called budding partners, and it's just a thought to tick into that. The second thing is, I actually sit on my own strategic planning board. I'm with Stirling and Clacks, and I made a definite decision. I didn't want to sit on an IGB fighting over councillors and local health authority about who's doing what with where. I sit on the strategic board because I think that's the engine room where we are. We are users of that service, and we have terrific stuff going on in the eastern villages. It's a neighbourhood care plan, and I would hope that at some point in the future that is good practice and that is brought to the group. Thank you.
Thank you. Question is, given the resources, Robbie, that you're getting 30 million a year, and given that we have obligations to protect the public and improve the public's health, would you consider charging for inspections of private health clinics, for example, Botox clinics, things of that nature, where there's an obligation imposed upon HIS, but equally these are strictly commercially run operations? Thank you.
So we receive income from registration for those clinics, so that's already factored into our income, and then that gets reflected in expenditure, so it should be neutral in that sense, so there isn't an additional cost to us. So we do receive that income, which comes to a cost of each year, Kevin or Alistair?
It's around £1 million.
Yeah, so there you go.
Thanks very much. My name is Zan McIntyre and I work for the Scottish Federation of Housing Associations. And as you can imagine, my question kind of relates to housing, or it's not a comment really. And it also links in with the well-timed Audit Scotland report today on the health and social care integration and the fact that it's stalling, that the resources are failing to kind of move from the hospital side of things and the clinical side into the community. And I think we all kind of share the frustration that we're not progressing as we kind of hoped. And we come with a view that home is absolutely central to people's health and well-being. It's more than just bricks and mortars, it's where people have their lives and spend their lives. But in my experience in a lot of conversations, this is quite often overlooked. I don't think that's intentional, I just think it's just part of the way that conversations have kind of transpired in the past. So if we do, I don't think anyone would disagree with the idea that home is central to people's health and well-being. So if we take that as a starting point, what kind of support can we have to enhance the conversations? Because the housing sector are really keen to engage, and we have had some success in that, and I know that the IHOP has also been supporting us to do that. But what more can we do to try so that we can be part of that conversation and help? And how can we, like vice versa, make sure support our health colleagues to make sure that they know that we're there to help them?
So can I kick off in responding to that, and then maybe bring in Ruth in respect of housing and homelessness and our work in our portfolio there. So if you were to look at the history of this in terms of housing and homelessness, it's had to fight into the National Health Service to be heard about the contribution, and it's been a struggle, to be blunt. But I think there is now a growing recognition that we need to see a more integrated model of thinking in the context of integration. But the fact is, if we look at the Audit Scotland report and the Glasgow housing options for older people, a great demonstration of actually proactive intervention and support for older people, giving them choices, giving them support, tackling delayed discharges, and doing some things which are actually pretty well low cost. So if it costs £4,500 to be in a hospital, but you could actually be doing something that might cost tens or a few hundreds of pounds, then I think that's where we're now having a more joined up conversation. But where we can help is helping to support that. But Ruth, do you want to?
And as you know, we now have the housing, place and home portfolio in the organisation, where we are working to look at the interface between housing and health and social care. It's been a real insight for me having this portfolio in, the enthusiasm from the housing sector, the resources that are out there, the desire to work more closely, particularly with health, but just how hard it has been engaging health in some of these discussions. And a key role that we see ourselves playing going forward is at that interface in terms of supporting on an ongoing basis those connections being made from the housing sector across to health, so that we can really start motoring on with some of the developments and the ideas that are there that would help enormously, both in helping people to live well at home, but also in some of the challenges that are there around delayed discharges. We are in the process at the moment of working very closely with the housing sector to look at where we focus that work from 1920. So it's a real opportune moment. We are holding various events, and indeed there was one yesterday, and particularly looking at the interrelationship around housing and adverse child experiences. And we will be, at some point in the next couple of months, bringing proposals out for where we're going to focus that work. So any ideas that anybody has, please do feed in. Key opportunity right now.
Any more questions? No? Okay. Well, thank you very much. Thank you for all those questions. That was really informative, really useful for us in HIS, and you've given us lots of things that we need to think about and take back, so thank you. So just a few closing words. We spent quite a bit of time today talking about our progress in 2017, 2018, but as Hamish quite rightly said, you know, it's November, so, you know, that work hasn't stopped, and we've been continuing to do what we can towards the delivery of better quality health and social care for everyone in Scotland. And in this coming year and beyond, we want to continue to bring the different parts of our organisation together in a more deliberate way and work to align what we do to help accelerate the shift in the balance of care. And we've talked quite a bit about that this morning. And as Robbie has already indicated, we've got a key role in helping to contribute to the delivery of the Cabinet Secretary's priorities. There will be tough choices about our priorities and challenges in how we implement our programme. And just to lift some of the examples that we're working on, we are working to support providers to design and implement new models of care. We will be working to embed the quality of care approach, implement the findings of the Scottish Health Council review, and apologies, I should have said earlier on that we should have been joined by Pam Whittle, who chairs the Health Council, but sadly she's not well today because she would have wished to be with us. We need to implement the actions from the Health and Sports Committee report on governance, both in terms of how we do business, but how we look at how others do business. And I think one of the big messages, and you've been saying it loud and clear to us this morning, is we need to focus on delivery and on demonstrating impact. Can I thank you for your attendance and for your contributions today? As I've said, they've been very helpful and thoughtful, and I want to assure you that we are listening. Can I now invite you to join us for lunch, where there will be opportunities to continue our discussions and to network. Thank you very much. That felt good. That nice.